Dan Prohaska. Dan is an orthopedic surgeon in Wichita, Kansas. I am excited tonight to talk to him on our journal club. I talk to Dan all the time, probably almost weekly, or definitely like every other week. I've known Dan. What year did you start, Dan?
2001.
2001. So I graduated school in 94 and started doing PT here in Wichita. So within, 8 years, Dan was here. And we've really worked side by side ever since then. He's just a fantastic guy. He's a great surgeon. He's a surgeon that's not scared to do complicated procedures. He's done probably more like crazy things that, he'll tell me that he's going to do it. And I say, are you sure? And he'll say, I think I can, I'm going to try it and I'll give it a shot. And he does just some crazy stuff, but it ends up working, which is cool, beautiful, and fantastic. So, Dan, you want to tell everybody just a little bit about yourself before we start?
Sure. Yeah, I'm University of Kansas School of Medicine, Wichita, clinical associate professor, but I'm in private practice, and that's where my work's done. I fellowship trained in Pittsburgh, so one of Freddie Foo's fellows, and lots of fun memories there. But my practice is probably 70% shoulders now, so I'm pretty heavy in the shoulder realm, and really enjoy that. And I didn't necessarily enjoy the fact that as I'm 55 and following in the age group of most of these studies, I fell victim of a rotator cuff tear myself this year. So I can share a little bit of that to the group tonight, and how that's going. It's an experience. I wouldn't recommend it to anybody, but if you have to go through it, you need to be prepared. So that's me. I've been here since 2001, practicing, and I remember the day that Rob walked in and said, "Hey, can I shadow you?" And I'm like, "Who are you?" And he goes, "Well, I'm Rob Manske." I'm like, "Well, shit, I should have known that." And so here we go.
That's the way it's been since, huh?
Yep, that's the way it's been.
I think, by the way, we start on the ground rules. I think Dan can share a few of those stories about the rotator cuff, but I'm hoping you'll slip in a few stories about Rob Manske, about what a dumbass he is there in the clinic, because you're about the closest person we know that can tell us the real story, what's happening there.
He'll be able to tell you. He'll be able to tell you that's a bunch of bullshit he tells you all the time. He's not telling you anything true.
What is epic about Manske is not Manske when I talk to him. It's when I talk to the patients that have talked to Manske, and he tells them stories. There's some epic tells.
Well, let's get past me and get started on what we're actually here for. Thanks, Voight. Where our articles tonight are on, essentially most of them are looking at starting early passive motion or delaying passive motion for rotator cuff repair. So I guess before we start, Dan, you just mentioned that you had a rotator cuff repair surgery. Tell us about your history briefly, how you think you injured it, how you think the surgery went, and how it's been going. And I think you can be upfront. I mean, these articles are either delayed or early, and we can tell them you waited and you kind of delayed your motion, delayed doing a whole lot of activity. We can tell them that up front, but that isn't going to impede really what we have to discuss in these studies. But tell them about your history and your surgery and how you've been doing.
Sure. I'd had a little shoulder pain for a while, and being in an orthopedic office, I had the ability to get an MRI, and I remember getting an MRI 10 years ago, and everything looked pretty good. Maybe a little tendinosis, but it looked pretty good. And then I had a little shoulder pain in 2019. I had an MRI, and it's like, there's a little more tendinosis, but I'm in my 50s, so whatever. So moving on, and then we built a new building. We had a new MRI. I'm like, well, I should get in the MRI to see what it's like, so I can tell my patients, what it's like when they're scared to go in the tube. And so I got in there, and it's like, oh, my shoulder's looking worse, and I better check this in 6 months, because I was really concerned it might progress. And so it's kind of a study. My own personal study is, in about 6 months, I progressed from a high-grade partial to a small full thickness. Well, it was almost a medium full thickness complete. And, that's the thing that I tell patients about and counsel them all the time. It's like, we know you have a tear right now, but in 2 years, that tear is probably going to be bigger by 50%, at least at a 60-year-old level. And I think that was what I found in my own journey with this. So I don't think there's any emergency to fix it, but I've had to find a time that I could pause my practice enough to get through a surgery. And I found out that at the end of May that I could probably do that. And get through the summer, and you always say, well, what's the best time? Slings in the summer suck, but slings in the winter suck. Anytime you have to wear a sling, it sucks. And but I went through it, and having an MRI scan, I actually was like, oh, it's 4 weeks. I hope I'm okay. Let's see what it looks like. So I've got some MRIs that I can show you as a progression at 4 weeks, 6 weeks, 3 months, and then I'm going to get one tomorrow at 4.5 months just to see how things are progressing. So my journey was, I was going to be pretty traditional, but I took every advantage I could. There's a couple articles, and I don't know how many people see this, but doxycycline is an antibiotic. That there are some animal models that show that it does help the tendon heal. It inhibits some of the bad things that happen in rotator cuffs when the tendon's not attached to bone. So I took that for 6 weeks after surgery. I took vitamin D, I took high dose vitamin C, and I took HMB. So I don't know if any of those things made a difference, but it made me feel better. So that's kind of the outside things that I may have done.
And you stayed in your sling 8 weeks?
6 weeks. No, I was in 6 weeks. But
okay.
But my surgeon was really kind of angry at me because I wanted to go back to work at 3 weeks to do surgery. And he said, absolutely not, 6 weeks. So I did it for him. And so what I did is I would put a wedge on my chest, and I would gown up, and then we'd co-band my arm to that wedge through the gown, and I'd operate with my arms down here like this. And so I did that for another 2 or 3 weeks, and then I came out of the sling and was real careful. And I didn't do my big surgeries till close to 3 months.
Yeah. And
I got a question for you, just out of curiosity. It's not the topic of tonight, but it sort of leads into it perhaps a little bit. But when you did your research, or you were trying to decide that you went ahead and for your repair, was there any discussion or consideration of using any of the biological patches or anything like that? And I'm sure you have good tissue, but a Regeniten or a BioBrace or something like that?
I looked at it, and, I have to tell you, I'm not completely sold on this because, a couple of years ago, everybody was, for example, talking about, the patch, or, putting a scaffold on for the superior capsule reconstruction. And how many of those that were on the podium 2 years ago talking about that are talking about it this year?
Right.
I don't think we're there yet. I just don't think we're there yet. There's a couple of them I'm like, well, I think that might work, but I wasn't convinced enough to try it on myself.
Gotcha.
What's someone posted a question about what is HMB?
It's a nutraceutical. That's a good question, because it's something that John Tokish, or Dr. Tokish, I saw at a meeting, and it's hydroxymethylbutyrate, and I don't even know what it does, but it's supposed to be one of those things that's good for you. So I took it.
If Tokish says it's good, it's got to be good. He knows all that.
It's got to be good.
He knows all that.
JT, if JT says it, everyone does it, right?
It.
Yeah. Well, that's funny. We need to get JT on here.
Yeah.
He would get on sometime, I bet. As I digress.
We wouldn't be able to get him off, but he'd get on. We never.
Yeah. That's the truth.
He's the only guy I know that reads like every article that comes out. I mean, that guy reads everything.
No, he's good. He's good for sure. One of our favorite guys when we go to our meetings. So let's start with our first article. Then it is by, do you pronounce this Riboh? R-I-B-O-H. Do you think, Dan? Do you know?
That sounds good to me, but I don't know.
Okay. Well, we're going with Riboh, Phil. Is that okay with you? You're cool with Riboh? Some of these studies, when I looked at this paper, some of these studies that they talked about were done with surgeons, or they talk about some of them from only fellowship trained surgeons. And I was wondering what you guys thought. How important is that? Because not everyone's a fellowship trained surgeon, right? There are surgeons that aren't fellowship trained that do shoulder surgery. Is it that important that the surgeon be fellowship trained? Can you be a good surgeon, shoulder surgeon, and not be fellowship trained?
You can be, but you cannot be too. And
okay, so explain.
Well, I think it really, if you're not fellowship trained and you have not spent time learning that, but you've got a high volume in your practice and you get pretty good at it, I think you can do pretty decent. But if you're doing 1 or 2 cuffs a month, and I'm doing 5 cuffs a day, I think I can out
be a little better. Yeah.
Because I've seen all the different patterns. I've seen all the different ways that things present, and then I see them in follow-up, and I can kind of, that's where years of experience can kind of help you and guide you when you see it. When you see something, you're like, well, experience it can really build your repertoire of how best to treat things.
Yeah. This isn't on our list of questions, but typically is our general like if you do general surgery, like general orthopedic, are there? I'm sure there are still people that do that,
There
right?
are.
I mean, people that do like foot, ankle,
Mhm.
shoulder, elbow, and knee. You know, they do a little bit of everything. Are they usually fellowship trained, or are they not because they're general?
They can be both. I mean, part of it is if you're in a community where there's a high concentration of orthopedics and somebody's got an established, sports practice, you may have to do everything to survive. Or if you're a foot and ankle surgeon and probably not foot and ankle, but total joints, and there's a lot of people around you doing total joints, you may be doing some scopes to just keep up.
Gotcha. What, Dan, what do you think? You mentioned you see 70% shoulder patients, so you see a lot of rotator cuff repair. You do a lot of rotator cuff repairs, and you see a lot of people that have torn rotator cuff repairs. I know because you've sent me people too that have had therapy maybe somewhere else and aren't doing well, so you see other people's work as well. What do you think is the most important factor in rehab? So I'm going to go to rehab now versus surgery. What do you think is the most important factor in their getting their motion back and getting their strength following the repair?
I think one, just the passive stretching, but two, if you don't get mechanics out of the gate, you're going to have trouble. And if you got bad mechanics and you try and strengthen, you're going to get pain, and you're going to just set yourself in a vicious cycle. So I preach this every day in clinic, and I send all these people to Rob saying, Rob, fix them, because they have bad shoulder mechanics. And over and over and over, I see this. And so I think if you focus on range of motion, and then you focus on mechanics, and then you can focus on strengthening, that's my triad to get a successful shoulder.
Yeah. No, I agree. And it can't be just range of motion. It's got to be kind of quality range of motion. It's got to be getting the normal arthrokinematics back. You can't just passively force someone's flexion or external rotation or abduction back. It's got to be integrated with getting the mechanics with the range of motion.
For sure, 100%.
Otherwise it's just almost it just seems futile trying to get it back. You mentioned volume, and I think I'm pretty sure that's kind of a big key too, right? I mean, like you said, if you see just a couple shoulder surgeries a week versus someone like yourself that's seeing, doing the surgery 2 and 3 days a week, and you're seeing 5 or more shoulder surgeries each of those days, the volume adds up pretty quick. That has to play, I think, a big key in whether people get better or not, and I guess even your patient selection, right? Trying to decide for sure who to do the surgery on and who not to, things like that.
And work comp variables and things like that. Really, to be frank with you, I mean, you really have to look at this and you say, well, you do a lot of rotator cuff repairs, and I do, but then you have to break those down in subsets, because all rotator cuff tissue is not the same. The muscle status is not the same. The patient expectations are not the same. And certainly the repair has to be done in such a way that has the best chance to heal and give that person a satisfactory outcome. And there's a lot of variables that come into play as you try to put a rotator cuff back together. And if you just go in and say, I'm going to do the suture bridge 4 anchor repair on everybody, which happens, it doesn't work on a lot of them. Maybe not a lot, but certainly a higher percentage. So you have to be able to think outside of a box of a marketed anchor technique so that you can make sure that the patient's treated well.
Yeah.
Can I jump in real quick, Rob?
Yeah. No, go ahead.
I mean, the synergy between you two is really cool, and I can see it, I can feel it, but I also know that we don't always get that. And I'm speaking from where I work and where I've treated patients for many moons, and there's not always that great communication. And so when you talk about tissue type, we talk about, even what you saw intraoperatively, Dr. Prohaska, I mean, that's so important for us therapists to know. Can you just speak to that? Like you said, I send them to Rob, right? Like, well, what if you didn't have a Rob, or what if
Rob
we don't
sees
have
a fraction of my patients, because I mean, I see a third of my patients are from 3 hours away.
Okay.
So how do I communicate with
Yeah.
I send every patient an email of their arthroscopy pictures with labels on them, and I say, please share these with your therapist. So therapists can look at that and say, oh, this guy really has some thin attenuated tissue. This is not great, but now I know what to do. And we classify in our rehab protocols, small, medium, large, massive, and we set out the parameters on what we're looking at for the rehab part of the rotator cuff.
And not only that, Dan does usually, I mean, with me, I don't know if he's this way with everybody, but he does a good job of even if there's something like important you need to know, like he said, it's that the tissue's really thin, so be careful with this person, for a while yet. Or I mean, he's told me before, I put the anchors in and I'm not even sure the damn things are going to stay. So like, go really easy for the first 6 weeks. Don't put a lot of stress on it. Don't overload it a whole lot.
Mhm.
He's very understanding about if he doesn't tend to get. I don't know that I've ever seen him mad, to be honest with you, and he doesn't really get too upset about much. He's very calm. He's that way in the clinic. He's that way in surgery. Um, and if things don't go right, he doesn't get like upset with you if things don't go right. Or at least I know with me, he seems very trusting of me. And if I tell him this isn't working, he understands it, and I feel like he believes it. And he's very supportive with patients of you as a therapist. And like when you have that kind of going back and forth, I feel the same way about him. I think I have patients all the time tell me that they're like they're at so much more ease knowing that I can call him or talk to him or text him and he'll listen to me and we can have a conversation. That just alone, I think, makes a lot of patients that are nervous feel at much more ease about their rehab and, their surgery and
Yeah.
all the things that are happening with that.
Yeah, my point for the therapist in the room is just like you get as much information as you can because everything, they're not created equal. Your rehab is not created equal, and you need to know as much as you can going into that rehab to do your best work.
I mean, if you go into a rehab of a rotator cuff repair and you don't know if it's a small or a massive tear, you're in trouble. Step one. And I don't know if all the surgeons give you that information. You see the scripts. I don't. I can only speak about myself. So,
Yeah. We have a couple of questions here. We'll just go to those while they're on. Peter Galt. Peter, thanks for joining us tonight. Dan, was there any consideration? I'm assuming this is talking about your surgery, Dan. Was there any, and I already know the answer to this, and don't get angry at this question, Dan. Was there any consideration to use a balloon spacer for your surgery?
oh no, that's not what I would need. I mean, balloon spacers, if you have a rotator cuff arthropathy, to make a space in the shoulder, and that balloon disappears in 6 months. And in 6 months, you'll see the balloons disappear. This is not going to be a long-standing trend. I think the balloons they're a neat concept, but they won't stand the test of time.
Right. Another question from Sarah Tyndall. Thank you, Sarah, for jumping with us on tonight. I've personally found communication on tissue bone health have almost been more helpful than size of tear when considering rehab progressions. I've only had a few docs in the past share this, but it's been nice. Great to hear this is the standard for you, Dr. Prohaska. Good. Great.
And we try to, especially if we get poor tissue, we try and make that known.
And then here from an anonymous attendee, Dan, how do you approach fatty tissue when you do your repairs? So someone who has maybe a more chronic cuff tear and has some fatty degeneration.
Well, fatty degeneration, I'm assuming you mean of the muscle.
Yeah. I
Okay.
so
if you've got a grade 2 or 3 fatty atrophy at the muscle level, I have to really think, is this muscle really going to contract and is it going to work? And I think that's one of the things that we're learning. And I think we've still got a ways to go is if you don't have a muscle that's going to contract, how important is that superior capsule? And how much is that cuff you're repairing just going to act as a stabilizer to keep that head down like the balloon's supposed to do? So in that situation, if I've got somebody that's got a really attenuated cuff, it's retracted past the middle of the head, and I've seen grade 3 atrophy on their muscle belly, the supra-infraspinatus, I have a very low threshold of using some autogenous tissue, and I will move the biceps into the middle of the humeral head, and I'll make a groove across the greater tuberosity, and I'll sew the cuff down in a margin convergence to that biceps tendon, not expecting that muscle to become a major player again, but expecting that head is depressed and that the deltoid can then fire and keep that head from flying up and hitting the acromion so they can have a good outcome.
Right. Is that, do a lot of people do that, or is that somewhat
You know,
unique?
I thought I was really cool. In 2020, I went to a meeting and thought, I've been doing this a couple times. I was afraid to talk to anybody. And then, you know, Tokish is up there talking on the podium, and there's a couple other people talking about, like, everybody was thinking the same thing. You know, I think he actually meshes the biceps tendon
Yeah,
and,
he talked about that
and
at a
flattens it
meeting.
out. But with the whole thing with the superior capsule reconstruction working for Hamada and Japan, but not working in America because we're using dermal tissue versus IT band, I was looking for something that was going to work and keep that head down. And it's, I will tell you, I've got massive tears that I send back work comp patients to regular work without restrictions. And it's, I couldn't do that without having that augmented tissue there from the biceps, I'm pretty sure.
Nice. We keep getting questions just as you're like, we're apparently stirring some thought process, which I think is good. From Kaylee Staler, I think is how you say it. Thanks, Kaylee. At what point are you sending your rotator cuff repairs to therapy? One of our docs does 3 days post-op. The rest do 4 to 6. As a therapist, I love to address the neck, the elbow, proper sling position, pain management, etc. When I have approached the other docs about trying to initiate it 3 days post-op, a lot of them talk about the literature of re-rupture with early rehab. What are your what are you finding is working best for you and your rotator cuff repairs?
So for about the first 20 years of my practice, I sent everybody to therapy
Early.
for 2 or 3 days. And I've kind of backed off on some of that because I have some people that are on a high deductible healthcare plan, and they come in and they say, I haven't met my deductible and it cost me $100 a visit to go see a physical therapist. And you really look at, okay, if I'm going to do 12 visits to physical therapy in the first 6 weeks, and I got 5 degrees difference in range of motion, is that worth it to those people? And so I've kind of backed off. And if you look at the study by Ribo, you know, when he talks about the risk factors for stiffness, this is when I'll send them early. You know, I'll send them early if they've got preoperative stiffness. I don't necessarily exclude workers' compensation, but age younger than 50, smaller tears, partial tears, anything labor rated, which you probably shouldn't be doing a 50-year-old, those go early because they have a higher tendency to get stiff. The other people I'll hold off. We'll teach them. I have an athletic trainer that works with me, and they teach them some passive range of motion exercises to do at their first post-op visit, and they do those until their 6-week point. And since I've been doing that, I have not seen a significant increase in manipulations or long-term post-operative stiffness. And I am a little bit of I am a believer that stiffness equates to healing. And so I don't mind a little stiffness early. I don't want it late, but I don't mind a little stiffness early.
So can you expand on that a little bit? Because a lot of people probably don't know that and don't fully understand that. So a younger age, a smaller tear and stiffer may actually be okay. And can you elaborate on that just a little bit?
Those are the people that are higher risk to get stiff. And so if they're going to get stiffer, and I know that, I'm going to try and preemptively stop that. And those are the ones, especially smaller tears. There's not as much risk for a re-tear, especially if you're moving those early. I mean, we can talk about, you know, active range of motion early to tolerance. The bigger tears, I don't ever have trouble with getting range of motion back. It's really kind of backwards. You think the bigger the tear, the harder to get the motion back. To me, it's the smaller the tear, the harder to get the motion back.
Yeah. What someone just posted another question, and this was a question I was going to have for you, Dan. What's your definition of someone being stiff? Do you just look at them and say, well, they're not moving well, they're stiff, or do you actually have a measurement criteria that you use?
I really don't care about stiffness. I'll just say this. I don't care about stiffness for the most part, unless it's associated with pain, and pain in particularly in external rotation. If they get to neutral external rotation and then they go to 10 degrees and it's killing them right here at the coracoid, they're in trouble because they're locked in. That's where the scar happens that you can't get out of with rehab and stretching. If they scar in that rotator interval at 3 months, you might as well think about at that point, or 4.5 months, if you want to really try and go one more, go in and release that scar because they're not going to get it back. That's been my experience. If you're going to have that kind of scar and that pain with external rotation, you're going to have to go in and I tell people all the time, you can't go in, and when I teach residents, you can't go in and manipulate these people and say, oh, they got great motion, and then stop and wake them up. You need to look in with the camera, release the scar, and then stretch them, because you'll tear that cuff apart because the scar is often stronger than that cuff tissue.
Than the tear or repair. Yeah. Interesting. David, I'm not sure how Gueli, Gueli. I'm sorry if I'm butchering that, David. It's said that 90% of rotator cuff re-tears occur within the first 3 months post-operatively. What can we do, treatment education wise, to limit those numbers within our practice? So the early re-tears. What do you recommend we as therapists do, or do you have any recommendations of things we do to try to slow that down or decrease that even more?
Robbie, you just froze up, but I'm going to assume that the first 3 months are probably the most critical time. And if you look at cuff repair and strength, after 3 months, you can kind of relax. But until 3 months, I tell people you've got to be careful because that tendon's healing, it's getting stronger. I make the analogy all the time of it's like a joint that you glued a wood joint and you put a clamp on it. And if you're going to use a sling for 6 weeks, that's the clamp, and you take the clamp off, but the glue is not completely set. If you push it too hard, it's going to shift, and you won't know it. It's going to go before you kind of. So you have to just gentle and I don't know how much passively you can hurt it by moving it, but I think actively is where you can get in trouble.
More trouble. Yeah,
More
so,
trouble.
So definitely limiting active. Aaron Hellam. Thank you for offering your time and expertise tonight. On a whole, it doesn't seem like the research has fully shown that healing of a cuff repair truly matters related to functional outcomes. What do you think of accounts for heterogeneous results related to cuff repair, healing, non-healing, and general positive function patient-reported outcomes? So some of the studies I think he's alluding to where they've probably done an MRI that showed that it's not completely healed, yet the people are still stronger and they feel better, and their patient-reported outcomes have improved, even though it's showing maybe they've got a re-tear or it's not completely healed. How do you account for that?
I don't know how those other surgeons operate. Mine are 100%, so we're good.
Yeah.
Not at all. I think that there certainly is that component, and I don't know how to explain it, because theoretically they had pain before the surgery, they should have pain after. We're addressing some pain generator that we may not even fully understand at the time of surgery. Maybe it's the bursa, but you can have a successful outcome without a complete repair healing. However, I think that probably works better in an older individual than in somebody that's in their 40s, 50s, or early 60s.
Is that just because their activity level? Maybe
just because their activity level. And
yeah,
just like if you have a tear, it's going to get bigger over time if you're active. If you don't have a repair that heals, you're probably going to have a tear that gets bigger over time, and you're higher risk for an arthropathy.
Which is not good.
Which is not good.
Yeah. Another question to Rob from Lori. Lori is on every month, isn't she? I bet Lori's been on. I don't know if she got on. I don't know if she got on. We'll have to ask her if she got on our first couple before we had her. But I bet after we had her on, she is on every Wednesday we have these. Love you, Lori. Thanks for joining. She said, which you guys know, those of you that know Lori, she said, I'm all about the lower extremity, but much more limited on the shoulder. Can you expand about assessing shoulder mechanics? Sure. It's simply looking at not only their passive range, but looking at like their scapulohumeral rhythm. It's looking to see how much passive joint play they have. So how much like anterior joint play, inferior joint play, posterior joint play. And really a lot of it is really kind of scapulohumeral mechanics. So looking at the 1/3 to 2/3 motion of the scapula. And as you're moving them passively, does the scapula like immediately go into, if you're taking them into flexion or into abduction, does the scapula automatically, at like 30 degrees of shoulder flexion or abduction, does the scapula start upwardly rotating already? And does it then turn into like a 1-to-1 ratio versus the 2-to-1 that it should be? So it's really looking at all of that and then figuring out, trying to determine address, is it soft tissue flexibility or is it capsular limitation of motion that you need to treat? And so can we stretch it by range of motion and stretching, or do we need to do joint mobilization and joint mobilizations and working on the arthrokinematics? Barb, Phil, do you have anything to add other than that? Oh, thanks so much. Lori says, thanks so much. What I thought and wanted to make sure I teach them well next week. Oh, thank you, Lori. Thank you very much. Thanks for joining us again. Dan, you mentioned the cost effectiveness. So this study, the first study by Ribo, showed that they achieved an overall 5 degrees increase in forward flexion over the 6 weeks of PT. And I think you mentioned, is that worth, whatever amount of money they're paying, or is it worth, if they're paying out of pocket, is it worth it? Seems like it would be a tough one to argue against. Is it, if it's, but I would even say then, is it even okay for us to make insurance pay for 6 degrees
Well, who
of
pays
range of
for
motion?
insurance? It's
Yeah,
it's the
we
people
do.
that are
Yeah,
prescribing to the insurance, and it's either the employer or the employee. So ultimately, you'll spread that out. Everybody's going to pay for it.
yeah. I think what some people, I'm just saying this to be devil's advocate. I think some people might say, well, what if we weren't doing the therapy? Maybe they would have been a lot tighter and been a lot worse. So you say, okay, well, they only gained 5 degrees, but maybe they would have lost, 15 if they didn't come to therapy. How do we know?
I
Does
think
that make sense?
that's the art of this. Is how do you know? You kind of have to pick your people, and you can tell some people don't have a tough mental fortitude to go through things, and they need a lot of handholding. And those people may need to go earlier. And you can sense that out pretty quickly when you're talking to them in clinic.
Yeah. The other question I had with these studies, they talked about early passive motion, and I don't know that they ever really address, does the early passive, and I'd like, I guess, Mike, Phil, Barb, Ashley, your opinions on this. And Ashley, I know you don't see shoulders, but it could be very similar to for hip patients, I would think. Does early passive motion have to be done by a therapist, or could if it's okay to do it, is it okay for the patient to do it versus them coming to therapy? Does that make sense? When these studies, they look at really the therapist doing the passive range of motion. They don't really take into account the patient doing it. Um, does that matter? Would that help it, do you
My
think?
thought is that it's really hard for patients to do passive range of motion. At most, it's probably active assisted in terms of them really getting passive. So I think that's hard. Sometimes I've resorted to, with people that live far away or have insurance constraints, to teaching a family member and making sure that they're competent in doing that for their patient. But I think that self passive range of motion is kind of hard to do, really.
But yeah, I think generally for 80+% of people, everything we're doing is like active assist. I don't know many patients who can
They're totally passive.
literally go
Shut everything off.
totally passive, where what we're doing is totally passive range of motion. So I think it just depends on the patient and how wound tight they are. And if I really truly, like, it's the same for us with hip patients, is like, I can tell when I start trying to move a hip or move a hip around, I'm like, okay, I'm not even going to bother trying to get this poor spouse to do this, because this
When
is
you're
going to end up in an
struggling,
argument. Like,
yeah.
this is just going to ruin their marriage.
Yeah, I have to agree with the ladies. My experience has been, Rob, just like yours with this. No matter what we do for passive, whether we try to do wands, pulleys, whatever, assisted arms, invariably it's always going to turn into an active assist. So then the question is, well, then how much active contraction is acceptable? Because they're going to go to that no matter what with it. And in some cases, Dan can speak to it, but in the early phase, that might be the kiss of death with some of these people that have bad tissue. So I'm tended to be what they said. I would teach a family member or somebody like that can help it if they need it.
I think what we haven't talked about really too is that we can as we're seeing the patient, you can kind of tell if they need, if they're moving okay, if they're tight and really restricted. And there's a lot of people that it's fine to wait the 6 weeks, because you wait 6 weeks and they're still not even stiff, so they didn't really maybe need therapy. And I don't know how you guys feel, but I would rather, well, I used to be, I probably still am, I'd rather be in control. So I'd rather see the person early rather than late. But I've seen enough of like Dan's patients now at 6 weeks afterwards that it doesn't really, it's not really a big deal anymore. I think early on when he changed, I would have rather seen him sooner, but it really doesn't matter. I mean, it's like, I I kind of compare it now to seeing a different type of graft for an ACL reconstruction. You may have a favorite that you'd like to see, but it doesn't matter to me if someone had hamstring graft or a patellar tendon graft or a quadriceps tendon graft. If you see enough of all of them, you're really comfortable with all of them. So it really doesn't matter. I mean, they still do well. Even though you may not see them for 6 weeks, they typically do well. So it really doesn't matter to me anymore. But I have to be honest. When this whole controversy started, I wanted to see him sooner, and I probably still do, but I don't mind seeing him later. I don't know your guys' thought on that, or if you have any thoughts on that.
I think a lot of that comes down to too, like, you know, what Dan was saying about he has an ATC in the office that's able to give them some good instruction. And we see some of these patients that I was helping my resident the other day, and this patient comes in, their sling's all jacked up. They're like super irritable because they're in a terrible position. They haven't had good education. They don't really understand what's normal pain, what's abnormal pain. And so I think if from the physician's office standpoint, if they've had great education, they understand, you know, how the sling should fit, what they can and can't do at home, how to bathe, all these things that we typically feel like we're responsible for doing, then seeing them at 6 weeks is no big deal. But when we see them at 6 weeks, they've had poor education and they've been walking around like this for 6 weeks. Now we're starting way behind the 8 ball.
Big problem. Yeah. That's Dan, we should give JoJo, your ATC, a shout out. Shout out to JoJo and the lime green figs. Right?
That's right.
The only three of us here got that joke. The other three are clueless as to that joke. Dan,
last week you didn't even know what figs were till last week. That's just, let's get down to brass tacks.
Hey, I got figs last year. They just didn't fit. Damn it. They were like way too tight. They were way too tight. They were just like uncomfortably tight. No one would want to see me in those figs.
Nobody even wants to picture that. So let's just
that's a mental picture. Get it out.
Yeah.
We thought you did that on purpose, Manske. They're like mediums.
I have that picture if you want to see it.
Yeah.
You wish. I didn't ever take any pictures in those figs. I wouldn't want those getting out.
Yes,
no,
you
I
did.
No, I didn't.
I got them right here.
Yeah, you send it to me. Send it to me and let me
All
see.
right.
All right, Dan. Some people on the
I think you should go to the group.
No, I don't want the whole group. In case I actually do have pictures of me in those figs, I don't want that going to the group. Phil, just send it to me first, please. I'm begging you. I'm begging you.
We're a team. It's a team.
Hey, I'm begging you. Just me. What about CPM, Dan? There's some people do CPM on shoulders. We don't. I don't know how many people do, but
I think that probably leads to more active assist than anything else. I mean, when you're sitting up in a chair and something's moving your arm like it does, and you are in that situation, I have not used it. It's been pitched to me a lot of times. I think maybe I asked Rob at one time, what do you think? And he gave me the negative.
I give you a thumbs down.
And so I said, well, if Rob doesn't like it, I don't like it.
Yeah,
so I think that's what I've stayed with.
I based mine on the literature, and the literature hasn't really bore out that it really is that much better than doing just passive range of motion or
I don't think anybody's even doing CPM on total knees anymore, are they?
No. No, Phil, these are not the tight ones. These are the ones we got these. Mike, he sent me the picture of you and I in our figs this year. That's not the tight ones. Yeah, that's not the tight ones.
He's dragging me into the fig story.
Yeah.
I'm in figs.
Yeah, you didn't even have anything to do with this. Why are they pulling you down?
I ordered the right size.
You have 16 minutes. Let's not talk about this.
Yeah,
I'm sorry. We're digressing.
The timekeepers in the group, the gals are going to say, let's move along.
All right. Well, we've got a lot of questions. We've got a lot of questions. But we got a lot of questions from people. Do you want me to go to the
I want to talk about discordant systematic reviews.
Okay, go ahead, Phil. You got the platform.
Rob, you said, what are those?
Yeah, what are they?
What are they? So what's cool about these is that think about it, you make a decision, and everyone uses these systematic reviews to make clinical decisions. And yet they have these overlapping systematic reviews of different years that include similar studies. So who do you believe? And I had heard about a JDAD's tool before for a quality appraisal, but not for discordant reviews. So I was really pleased that this JDAD algorithm for discordant reviews was included. I actually learned how to use that tool to determine what do you believe. But it really just, it boils down to, you use the best quality study of the highest, randomized controlled trial with the most the least risk of bias to make your decisions. And the problem is that every systematic review is a little bit different. They may have inclusion exclusion criteria that are a little bit different, or data extraction, or statistical analysis that are all different. And so this is why as a clinician, it's important when you see even one systematic review says this, another systematic review says something different, what are you going to do? And that's what this tool kind of helps you to decide. But at the same time, I found another study that said that when they actually applied that algorithm, it doesn't always work. So it's really important for us as clinicians to, not just believe or listen to everything that's in the literature as it's stated. Dig in there, find out what they're talking about. And this is why it's important to be an informed consumer and a critical appraiser of these literature reviews, so that you can make a better informed decision as a clinician and not just take the word of the authors, because it really is contextually based on what you as a clinician want to know in terms of your answer.
So for those of you that are lost, kind of like I was for just a moment,
What?
Phil jumped to the third article without letting us know.
No, you said I could do it. You said.
I know, but I thought you were talking about our first article. You jumped all the way down to the Hauk article.
But you asked about the jaded or the JEDEC.
Phil did.
algorithm.
Phil did. Yeah.
No, you did, Rob. You asked me that.
I did on the list, but we still had another article to go. It's okay.
All right, never mind. There's 9 questions, and the Q&A is probably better fodder than I have. I'm pretty boring when it comes to all that research crap. I know.
First step to recovery, Phil.
Yep. All right. What do you guys want to do? Do we want to go with the viewers' questions?
Take a few questions. We'll try to hammer out that third one.
Try to
Get a
hammer
couple
out the
good
third.
questions for Dan.
Okay, here we go. So, anonymous, let me go back up to the top here. Stephanie Moyes, when you start therapy, Dan, it's 6 weeks post-op. Are you still going through the protocol as written from post-operative day 1? Or do you jump to your week 6?
And that's a great question. Typically I expect to jump to the week 6. So you may be doing a couple sessions of catch up to get to that point, especially with your early range of motion. I found out when I went for my 6-week stretching program, I was tight, but after a couple sessions it really came back. So catching up is pretty easy to do.
So most of the protocols will start day 1, even though you may delay 6 weeks of rehab. They still have a week 1 through 6 or whatever. Yeah.
Right. But when if your week 1 through 6 is phase 1 and you're going to phase 2, when you walk in the door, you check to see if phase 1's checkbox, and you move on.
If they've met those criteria. Yeah. Okay. Anonymous attendee, what are your thoughts on therapeutic laser application to shoulder postoperatively while the patient is still in the passive range of motion active assistive phase earlier than 6 weeks? So doing therapeutic laser.
I really don't have an opinion. I've had some people, I've had a veterinarian that said she had it and she used it on herself. And this was after an ACL, and she said she had to stop because she felt like she was getting too much tightness because it was getting too stiff. But that's my only experience with therapeutic laser.
Yeah, we don't have a lot of people. Are there therapists? And we don't have laser at our clinic. Are there clinics in Wichita that you see patients for? So you don't see a lot of laser, I'm guessing.
Only for veterinarians.
Yeah. Okay. All right. Beth Pierpoint, I wonder what is the average months of treatment for delayed versus early in your practice? I wonder what is the average months of treatment for delayed versus early motion. I'm guessing she's meaning how long of treatment of rehab typically with delayed versus early.
I'm guessing what's the total time in rehab. And I think that, that's one of the reasons I do this, because some work comp carriers have a certain number of visits they want to allow. And if I start them at 6 weeks, then I can, I feel pretty comfortable taking up to the 6-month point and saying, we're going to do another round of therapy. And if you start them at day 2 or 3, they're starting to get crabby after, that 16 session period where they don't want to continue that episodic care if they can help it. So you got to write letters and keep things going. And that's the other genesis of why maybe delaying therapy. But total time, I don't think I don't think it expands your total time in therapy. And I think maybe, you're going to get by instead of doing 12 weeks of physical therapy. Maybe if you start at 6 weeks versus 18, I think you can get by with a little less sometimes, because those first 6 weeks may not be as fruitful as you want them to be.
Yeah. Gus Gutierrez, does someone want to take that question?
Gus,
Phil,
that's my
I'll let you or Barbara.
homeboy.
Do you know
Way to
Gus?
go, Gus. I
What's
don't know
his question, Phil?
What's the question?
He's really just making some points. He just said that the three things that he thinks of are three major points: communication with ortho, every shoulder is unique, and early motion education has worked well for pain relief and therapeutic alliance building. So just kind of agreeing with what we've been talking about, essentially.
Nice.
Shout out to Gus.
How do you know Gus, Phil?
Baton Rouge Physical Therapy.
Yep. Shout out Gus.
Shout out.
Eddie Austin, Dr. Prohaska.
Oh, another one. New Orleans, Baton Rouge, Eddie Austin.
Eddie Austin, Phil, you're coming.
What the hell,
tonight.
Phil?
All Phil's friends. Way to
That's
go.
Marketing, baby. Marketing.
Dr. Prohaska, when you speak about referring at 6 weeks, have most of the patients failed in therapy preoperatively? Does this factor in whether you do a post-op PT visit before 6 weeks? So you don't send, not all of your patients, I don't think, go to therapy before surgery, do they? Some people.
No, I mean, I see so many people that refer to me that have been to their primary care doctor and they've done 6 weeks of therapy, and then they got their MRI or they've been through work comp, and typically work comp, if they get the MRI and it's got a rotator cuff tear, they jettison them off, and those people all operate on fairly early most of the time, because that's the way you're going to get them through the system and get them healed and get them moving on. So not everybody gets therapy before surgery. So I don't know if I could say I have a real opinion on that.
Hey, Rob, if Ed Ogeron or Brian Kelly asked the question, I'm hanging up.
If what? Say that again. If what?
Ed Ogeron or Brian Kelly, coaches at
Football
LSU.
coaches.
He's got all his Baton Rouge online.
No kidding. Isaac Murdoch. Dan, you might be able to answer this. They're asking me, but you could answer it, I think, just as easy as I could. As a PT student, Rob, what did you do early to cultivate a relationship you have with Dr. Prohaska? From my experience, observation so far, it's rare to get such fruitful communication with physicians. What is it you think? So think about the therapists that you really like working with, that you get along well with. What is it about us, those of us that you do like, that make you want to work with us?
I can genuinely say I have therapists that come shadow me not infrequently, but the ones that come in and they don't say one word and they just are a fly on the wall, and then they say thanks at the end of the day, I really build no rapport with them. But if they come in and say, well, I saw this patient, what do you think about that? Or I did this, do you approve of that? And build some kind of, banter back and forth, or talk about a patient, or ask genuinely interested. Those are the people that I remember and say, okay, I like this person, and I think that they would be good to help my patients. So, if you're going to go spend some time shadowing a physician, try to engage them, try to find out a way to make yourself applicable to their rehab process.
Dan, I know another reason why Dan likes me. He likes it when I send him chicken Instagram funny chicken Instagram videos, like
That's
roosters
exactly
and
right.
chickens and stuff.
Yeah, and the morning salutations, Rob. Those are
See, I send those to Mike too. Yeah.
Can I jump in real quick on this one too? I'll tell
Yeah.
you what really worked for me. A long time ago, I was asked to join the AOSSM, and if you as a therapist can talk language that physicians understand respectfully, as well as knowing what you don't know, that physicians are like, I one time stood in on a rotator cuff repair and I said, tell me about this, tell me about that. And the surgeon looked at me, he's like, how do you know about this stuff? And I said, well, I read voraciously and I go to these meetings that help me understand what you do so I can better understand what I need to do. That's just another helpful hint that really worked for me early in my career.
Yeah. I think just and being like just being nice for one thing. I mean, it's amazing how many things can happen if you're just kind and nice to people, versus like Dan says, not saying a word to him the whole time that they're doing the surgery, not asking him a single question. Um, just be kind and be polite. I think is really helpful. Thoughts on the sleeper stretch? This could go to anybody. Thoughts on sleeper stretch? I just lost it. Where'd it go? Thoughts on sleeper stretch, whether in post-op or just general stretching. Are any of you in favor of the sleeper stretch for shoulder problems? Mike, you don't see shoulders probably very much, do you? Ashley, you don't do the sleeper stretch. Phil, do you do the sleeper stretch? Are you not seeing shoulder patients, Phil?
I think it's just generally done incorrectly.
Yeah,
Fairly
I would agree with that.
regularly. It's kind of like how I feel about clamshells in the hip. Like clamshells are not a bad exercise. They're just generally done very poorly. So I just don't assign them.
Yeah, I think the sleeper stretch is still a good stretch. You're right if you do it correctly. If
it's done correctly.
If it's done correctly,
in the clinic I do it. In home exercise I don't.
Yeah, if it's not hurting, if it's not causing them pain, and they're doing it appropriately, it's a perfectly good stretch. I still think. So hopefully that answered it. And my thing is moving. It's like jumping. I think there's so many questions people are asking. This is the most questions we've ever
Sorry,
had.
this is me. I'm like checking them off as we answer them. And I keep messing up.
Anamika, maybe Corbett, in regard to utilizing BFR. What is your stance on BFR, Dan? That's a good question.
Maybe Rob, you could talk about that a little bit.
I probably should.
We are actually both involved in something we hope is going to be meaningful.
We're just starting a study where we're doing BFR with some of Dan's postoperative rotator cuff patients. We're starting it after they get out of their sling, and so it's dependent on the size of the tear. And we're doing it for 6-8 weeks. We have a kind of a protocol. It's a really pretty general protocol. It's not a really aggressive BFR protocol. So we're going to do it, follow these patients out. Jojo, again, shout out to Joe's doing our strength testing when they come back and see Dr. Prohaska at various timeframes. Hopefully, in a year or so, we'll have enough patients we can look at some data to see if doing BFR actually helps or not. I think patients like it. It seems to work. You're doing lighter load with the BFR on to try to get a hypertrophic response with a lighter weight. It's not totally new, but patients kind of see it as new and I think kind of exciting, so they like it. I'm just not 100% sure. What I've seen from the studies, they're kind of inconsistent. Some show that it does help, some show that it doesn't. We did a study. I don't have it published yet, but we finished it. We did a study where we did just posterior cuff exercises with students or PT students doing BFR versus doing the same weight and load non-BFR. And the BFR patients didn't get any stronger than the non-BFR patients. And now those they were healthy, a normal healthy population that probably didn't need BFR. So maybe that's, the limiting factor there. They didn't need it. So it didn't really show any benefit.
But I've never understood that, Rob, aren't you doing brachial artery occlusion and you're working on the rotator cuff?
Yeah. So it may not. It's proximal to the cuff, and you're right. Most of the studies have shown that it does strengthen distal to the cuff, not proximal. I think all of us that see a lot of shoulder patients are just still hopeful that maybe it will magically work through the systemic effect of the
You do the same thing in the hip.
Yeah. You may be better off, and we've talked about this a little bit. Doing a thigh tourniquet if you're getting a systemic effect, because you're going to have a bigger muscle group. You're going to occlude.
Yeah, and you could do that. You could do that you could do it with cuff patients. Put a tourniquet on thigh, have them do leg exercises.
I think we've got a long ways to go on understanding BFR for the upper extremity. I'll just leave it at that.
Yeah. And the concept, as Ash said, the concept's the same with what we do at the hip. With the hip, so we're having it on thigh, but for proximal.
Tony, how long do we have, guys?
1 minute.
We're almost time. Do you want to pick one good one?
How about It seems tonight's articles are fairly specific to just cuff repairs. I can hardly remember last time I received a patient who hasn't also received a subacromial decompression, biceps tenodesis, DCE, general cleanup, or all of the above. Does this change your thoughts on early range of motion versus immobilization?
No, I wouldn't change it at all. And I think that, there's very few of my patients, probably 15 to 20% that are an isolated cuff. They all get a biceps or a decompression, or very few DCEs. Some of the literature is starting to point away that doesn't make really a big difference. And so I don't try to add those on unless I really need to.
You're not doing as many subacromial decompressions as you used to either, are you?
Not as many. I do it sometimes just because it gives me space to work. And if you look at the biologics of it, if you think of the marrow coming out of that, could that potentially help the cuff? Yeah. So I have a hard time, and I look at that, and if the tissue is all scuffed on the undersurface of the coracoid or the coracoacromial ligament, I have a hard time believing that doesn't have some role in why that cuff is torn. So I'll take it off. I'll do a decompression.
Yeah.
Mhm.
All right, guys. Any final parting notes? Thanks, Phil.
I like to thank Dan for coming on. Share
Yeah, that was great.
personal experience.
And,
No, I thought it would be good because he's had it done. Yeah.
Thanks for having me.
Yeah, you're welcome. We'll get you again. We'll get you again on another topic.
Appreciate your
hopefully.
input.
Yeah.
Definitely appreciate it. All right. Well, we will be back next month.
It's foot and ankle, I think, next
Okay.
month. It
We
should be
haven't
our
done foot and
first foot and ankle. Yeah.
Nice.
Yeah.
All right, so that'll be coming out soon. Again, you should receive certificates in the next 24 hours. If you don't, email me, and the recording will get posted on our YouTube channel. Thanks so much to Dan for being on here, and for everyone who joined us tonight, and everyone have a great rest of your week.
Thanks, guys.
Thank you.